the House Committee on Healthcare to order for this happy day after Oregon's birthday, February 15th, and make a couple of comments first. I do not intend to reopen for another public hearing House Bill 2133. Representative Thompson's not here yet, is he? We have an amendment or more coming on that, and the real issue that we're dealing with in this is the role of the citizens advisory committees in the CCOs. We think we'll be putting together a work group on that issue to look at the broader question. This bill is one way of looking at the role. Incidentally, just for the record, we checked on when the recertification of CCOs come, and it comes after 6 years. So if we pass this bill, there'll be plenty of time to figure out how to implement it by the CCOs. But our interest, rather, in Representative Thompson and I and Representative Kenny Guyer really believe we need a serious discussion of the role of the citizens involved in CCOs, and we're going to put together a work group to see that happens. So we will not be opening up a public hearing. The next time we'll see it, if we see it again in this session, it will be for a work session. But we are going to put together a work group, and I think Representative Thompson is going to lead that work group, although he's not here right now, but I think that's the plan. But what I would like to do now is open up an informational meeting and ask Tricia Tillman to join us to give us some background for the discussion of the two bills that will follow.
Okay, well, good afternoon, Chair Greenlick and Vice Chair Kenny Guyer and committee. My name is Tricia Tillman, and I'm the Director of the Office of Equity and Inclusion at the Oregon Health Authority. And I want to thank you for the opportunity and the impossible task that you've given me, Chair Greenlick, of presenting to you in 15 minutes the key points related to health equity. To inform you as you begin your deliberations today, but also hopefully to inspire you to continue to advance health equity throughout this legislative session and beyond. I have prepared probably more than 15 minutes worth of information, but what I don't get to, you'll have in your PowerPoints. I think you have them in front of you. And I'm happy to meet with you again as a committee or individually to dialogue further about any part of this presentation. So as I start, let's start by thinking about how we define health. When you think about your own personal health, do you think about it as merely the absence of disease or infirmity, or do you think about it as a complete state of physical, mental, and social well-being?
I got news for you. In my age, the absence of infirmity is pretty good.
Good. But that you're here is a state of well-being.
It changes with time.
Actually, I was in Cornelius this morning at Virginia Garcia Clinic, meeting with a number of Latino families who have children with disabilities, and we started by asking them what do they think about health and how do they define the concept of health. And they were very clear that they defined it in terms of physical and mental health, which was good, but also in terms of spiritual health and intellectual health and understanding what kind of health information they needed to know to help their children succeed. So that was really encouraging. So these are some of the factors that promote physical, mental, and social well-being, and we can think about how these all show up in our lives. Again, the families in Cornelius, they really loved the feeling of connectedness in their small town. And they also experienced serious barriers to health care and to health in terms of being able to access parks for their children who had physical mobility challenges, and also to swimming pools where they wanted to be able to take their kids so that they could get exercise. So health equity, how do we talk about that in the context of a state of complete physical, mental, and social well-being? And as you look around this room today, it may be easy for you to imagine that some of the people sharing this space with you today have experienced challenges gaining access to the factors that promote physical, mental, and social well-being. They may have experienced barriers beyond their personal control to influence. They may have experienced war trauma, been separated from their families and communities in order to find work or safety. They may have experienced situations that undermine their sense of human dignity or their ability to live in healthy homes. They may have inherited traumas that were experienced by their ancestors and live each day without being able to speak their native language or even the knowledge of what country their families originate from. So in order to achieve health equity, we need to not only address specific health behaviors and meet people's individual health needs at the doctor's office or the clinic, but we have to also address societal obstacles that prevent individuals from achieving the highest level of health. And achieving that highest possible level of health for everybody requires tailored strategies and specific efforts to improve health of people who have experienced disadvantage, whether social or economic. So that takes continuous effort. It means that the strategies that we put in place for the families in Cornelius might not look the same as for refugees coming in from Southern Asia or from Africa. So we have to think about how those strategies might look different. So health inequities are not about individual behaviors, though undoing them does require individual behavior change at every level of society. It requires individuals to make healthy choices in their daily lives, but it also requires that healthcare providers, policymakers like yourselves, city planners, housing developers, and others to make choices in our daily work that promote health. So as an example, the families in Cornelius talked about how the city planner now comes to them when they're planning a new park to make sure that the facilities will be accessible to their children. Health inequities are the evidence of systemic unfairness over generations, and none of us probably created health inequities ourselves, but as leaders, we are needed, all of our efforts are needed to bend the curve back towards equity. And we can't do nothing or do everything the same way we've done it and expect to change. So what are the causes of health inequities? We categorize them in terms of barriers to healthcare access, differences in quality of healthcare, and the social determinants of health. And it was really interesting to see how this played out this morning in this conversation. The families that were there today talked about how they had to wait weeks or months to get access to health care for their children. These were children with special health care needs, having to wait years to get reevaluations done for their children to determine whether they have autism or attention deficit, and all of this impacted their family stress as well as their children's ability to perform in school. In terms of differences in quality of health care, the families shared that they had been told by several providers that if they couldn't lift their children up onto the exam table, that the providers wouldn't see them. And when they're talking about their children, they're talking about 17-year-olds, 16-year-olds, hefty children that parents, I couldn't imagine lifting my child up onto an exam table. And then the social determinants of health are the social conditions in which people live that lead to differences in health outcomes. So a patient in my neighborhood, with diabetes, might leave a clinic with directions to decrease salt and fat intake in their diet. But before they get home from the clinic, pass the McDonald's, the Kentucky Fried Chicken, the Popeyes, the Burger King, and the Wendy's before they're able to get home. And if they're working 2 jobs and have kids who are hungry, it's real easy to pull into the drive-through. So what are the causes of health inequities?
How many people?
So We expect to see differences in health outcomes when we're comparing an individual with a diagnosis with an individual without a diagnosis. A person with diabetes is more likely to have eye disease than somebody without diabetes. And a person who is frail and elderly is more likely to experience devastating falls than someone who is young. So some of the disparities or differences, while important and while they require targeted interventions, are not as avoidable due to physiological, or psychological conditions. However, some differences are unjust and avoidable. Differences in access to quality of care, such as differential treatment, experience of discrimination, and lack of cultural competency, are often more related to the perceptions of the provider rather than on the individual's actual insurance status, ability to pay, or diagnosis. And those perceptions are often rooted in personal and institutional bias. Throughout most of our history, both as a state and as a country, racism, discrimination, and the resulting lack of political and economic power of communities of color, immigrants, and refugees were explicit in policies and practices. And while many became illegal with the Civil Rights Act or the Americans with Disabilities Act, full understanding or commitment or compliance with these laws has been slow. So I want to share just a couple examples of how social determinants play out in terms of health equity in Oregon. So in 1954, Western Oregon Indian tribes were terminated, which abolished tribal governments, ended federal services, and sold off tribal lands at a fraction of their value, and was intended to disrupt family stability, economic stability, education, and health, with the explicit purpose of assimilating American Indians into the dominant culture. And in terms of how this connects to health, diabetes, which was virtually non-existent prior to this, now is one of the more prevalent health conditions among American Indians. So there's also more current illustrations of this. A 2008 Oregonian study showed that Black and Latino borrowers in Oregon were twice as likely to get a subprime loan as whites of the same income level, even after controlling for income or credit score. So these consequences of predatory loans are now experienced by many Oregonians, but have been particularly impactful in the African American community. We know that home ownership and housing stability is a health protective factor. So there are many ways to look at health inequities. We can understand them by focusing on the singular factor, either by diagnosis. We know that people with mental illness have a shorter life expectancy than people without a mental illness. We can look by population or by geography or by risk factor. But where we look as an office is where these factors intersect. And oftentimes, as institutions, we don't look at that level of intersectionality. So, for example, again, the families in Cornelius experience language barriers, cultural barriers, also dealing with children with a disability, living in a rural community. All of those factors contribute to health inequities. And when we just focus in on healthcare, we see the same patterns. So the Institute of Medicine published a report in 2003, and they found significant variations in the rates of medical procedures by race, and this was even after controlling, again, for insurance status, income, age, and severity of the condition. And they found that U.S. racial and ethnic minorities are less likely to receive even routine medical procedures and experience lower quality of health services. Minorities are less likely to be given appropriate cardiac medications or to undergo bypass surgery, and are less likely to receive kidney dialysis or transplants. And then minorities are more likely to receive certain less desirable procedures, such as lower limb amputations or other treatment. So why is health equity a priority? Here, of course, we're acutely aware that we are expected, through Oregon's health systems transformation, to produce a 2% reduction in healthcare costs. But in a national study that was released in September 2009...
Can I comment on that? Just
Yes.
make sure. We're talking about a 2 percentage point reduction in the increase in costs.
Yes,
We're not talking about a reduction in costs.
in the increase.
In
I'm
the
sorry,
rate of
yes.
increase, right.
Sorry about
And
that.
it's not 2%, it's a 40% decrease in the increase in costs.
The decrease
2
from
percentage
5.4 to 3.4%.
Right.
In the increase, right.
Right.
So bending the curve. But the study that I'm referencing put a dollar amount on the actual cost of health disparities. And this was a national study, looked at costs, both direct and indirect, over 3 years. And the dollar amount nationally was $1.24 trillion. And if we only looked at direct medical care expenditures in these 3 years, the cost was $2.29 billion. So knowing that we have communities where there's significant diversity in our Medicaid population, it's going to be really challenging to meet our goal without addressing health inequities. So what we know is that 40% of the Oregon Health Plan enrollees are people of color. What we don't know, because of the quality of our data at this point, is within the white population of the Oregon Health Plan, how many of those are Eastern European immigrants or refugees. 18 of Oregon's counties have a Medicaid population that is more than 25% non-white. 8 have Medicaid populations that are more than 50% non-white. And 3 counties have a Medicaid population that is majority Hispanic. And this slide shows that when we think about diversity across the state of Oregon, it's not, as many people believe, the diversity is not solely located in the metro area. It actually spans the state. So how can health systems promote health equity? Well, the good news is that there's a lot that can be done, and there are roadmaps and blueprints that exist and best practices that include all aspects of health promoting organizations, from human resources to communications to service providers and the front desk staff. So the Institute of Medicine report presented a number of recommendations. I'll highlight 2 of them. Number 6, number 6 and number 8 are ones that you'll be talking about later today. Their recommendation, number 6, was to collect and monitor data on patients' access and utilization of healthcare services by race, ethnicity, and primary language. And number 8, their recommendation was to provide healthcare professionals with tools to understand and manage the cultural and linguistic diversity of patients seen in today's health systems and avoid allowing unconscious biases and stereotypes to affect their interactions with patients, both during training of future healthcare providers and through practitioner continuing education. The Joint Commission, which accredits many of the hospitals and larger health systems and some federally qualified health centers, also has recently implemented standards for promoting health equity and patient-centered care. And I'll focus on the third one. They have requirements for the collection of patient-level demographic data on preferred language, race, and ethnicity in order to provide hospitals with information on the potential needs of each patient and to monitor and analyze health disparities at the population level. And this is a blueprint that was, or a summary of a blueprint that was published by the National Public Health and Hospital Institute in partnership with the Institute for Healthcare Improvement. And I think a lot of folks are familiar with Don Berwick. And I'll focus here on the 3rd and the 5th bullet. They recommend in their blueprint providing evidence-based care to all patients in a culturally and linguistically appropriate manner, And number 5, communicating in the patient's language, and that providers understand and be responsive to cultural needs and expectations. And then the National Committee for Quality Assurance, they have established a distinction in multicultural healthcare, which any health system can apply for that distinction, but they have to meet certain standards. One of which is collecting race, ethnicity, and language data, using a system of effective data storage and retrieval for ethnic and linguistic information, reporting the HEDIS diversity of membership measures, and then identifying threshold languages spoken by 5% of the membership or 1,000 members, and then that would trigger different kinds of ways that the health system would respond in terms of having on-site healthcare interpretation and proper signage and proper translation of documents. They also focus on reducing health care disparities, again, collecting, reporting, and analyzing clinical quality and patient experience measures by race, ethnicity, and primary language, and comparing outcomes among members of different backgrounds so that the health systems can make targeted interventions to improve disparities in relevant care measures and continually evaluate their effectiveness. So just in closure, almost 50 years ago, President Johnson signed into law the Civil Rights Act, which was not only a watershed moment for civil rights, but it also created a platform on which many could begin to move toward health equity. I think many people, for over the span of our history, we're really a generation in to closing some of these devastating healthcare gaps that are affecting many populations in Oregon. With increasing diversity among medical health research and public health professionals, we've increased our focus on health disparities and health equities. And the wonderful thing is that we can learn from the efforts of the Institute of Medicine, the Joint Commission, the National Committee for Quality Assurance, and increasingly from hospitals and health systems in Oregon who are implementing health systems transformation to identify strategies that can help Oregonians achieve the highest possible level of health while decreasing costs and improving quality. I can take any questions if there's time.
Well, how about if we give you an opportunity? Do you want to comment on either of the bills coming? I know you can't take a position on them formally.
I cannot take a position on them.
Would you
however,
care to comment on them?
Yeah, both of the bills that are coming forward, I think, align with a lot of the information that I've shared with you today. We have been working in the Oregon Health Authority and the Department of Human Services together to identify the disparities that exist. Gloria Anderson's also here and can talk a lot about it from a human services perspective. But we know that there are disparities. We know that collecting better data can help us to know how to target our interventions and how to invest our dollars most appropriately to close those gaps. And we also did staff a committee focused on cultural competence, continuing education, based on a willingness and an interest from a number of stakeholders across the board who were interested in understanding what cultural competence continuing education options exist and what the research is that supports that. So that report is available. We can share it with you if you're interested in that as well.
Tricia, thank you very much. Are there other questions? Representative Thompson.
Are there ways to incrementally adopt this over a period of time in a stepwise fashion? I know what you're saying, and I don't disagree with any of it, but the problem we have is the problem is so big. Has anyone taken basically what you presented today and said, let's do this piece and this piece and this piece in order of, so we can have something to build on a foundation?
We do not have a specific plan for how to address health inequities statewide. Washington State, a number of states have developed their plan for eliminating health inequities. We haven't done that.
One of my concerns is we tend, and we've done this in other areas, we adopt a new policy that this is the direction we're going to do, and then we throw it on the wall, and it kind of collapses under its own weight. There aren't enough resources or people, which are resources, or not, to make it all happen. So there has to be a strategy for what do we do on day 1, 2, 3, 4 down the line, or year 1, 2, 3, 4. What are the biggest problems that we can address within the system we're in? One of them that I'm very concerned about, and it comes on to this very, very big, is I still do not believe, as we do this flip to transformation, we have enough primary care provider bodies. And I know we don't have enough primary care physicians. That's over. But how do we address all of this and healthcare transformation with the people we have on the ground, utilizing them differently? And I think this feeds right into that, because my guess is, in a constricted situation, a lot of your people are going to get more left out if we don't find a way to encompass the whole thing. And initially, it is my hope that we'll find a way to take all the qualifying patients, put them into medical care for at least a baseline study, an evaluation of where they are as individuals. That's a Herculean task. So the last thing I want to do is provide coverage to a huge number of people that can't get in to see a doctor. That's not health care, that's something else. And so it's how do we make all of this work in an equitable fashion with the resources we need? I don't know.
So one of the things that I would just offer is a lot of what we have offered up as best practices are already built into health systems transformation. So this is really about thinking, providers outside of Medicaid right now, that's huge. How do we assure cultural competence there? The standards around race, ethnicity, and language data, there are some standards that exist. We can do more as agencies to support our providers in knowing exactly who they're already working with so that they can work with them more effectively.
You can call her up again later, right?
If she wants to be. You have a question, here's a chance.
Well, I know that you've been doing a lot of work on the culturally competent care piece over the last couple of years, and I'm just wondering whether it's more appropriate to ask her about that now or wait until we actually hear that bill.
She hasn't volunteered to testify, so you have her in front of you now.
Okay. So we're going a little out of order. We've got the data equity bill and then the cultural competency. But I know that you've been doing a lot of work on that with a big task force. So maybe you could let us know a little about that before we formally open the hearings on each of those bills.
Sure. The Cultural Competence Continuing Education Committee, it's a big mouthful, we couldn't make a nice acronym out of it. We pulled together representatives from the licensing boards, from the healthcare professional associations, from individual practitioners, academics, community members to look at 3 things. One was, can we identify a solid definition of cultural competence? That was something that had come up before. So what's the best definition of cultural competence? And are there standards for what would count as cultural competence continuing education? We hadn't identified those before. So we wanted, we had heard from folks that there's some good cultural competence continuing education, and there's some that, maybe isn't so good. So what's a standard? So that was the first task. The second task was to identify what are the continuing education options that exist, whether they're online, in person, service learning. And what we found there was it was this giant apple that we could only take a bite out of because, so, like I mentioned before, there are so many entities that are now looking at cultural competence continuing education that there's just more and more continuing education options that are being developed. So we identified a number of them. that would also address some of the issues that had been raised around geographic access or specific professional discipline. So pulled those together as well. And then the third piece that we looked at was what are some of the logistical challenges that the licensing boards would have to address in order to encourage their licensees, if it was about encouraging, or in order to mandate that their licensees participate in cultural competence continuing education. So we came up with a number of recommendations, some of which I think are very doable within the resources that we currently have. Our co-chair of the committee is also here, and I believe she's going to testify on it as well.
Okay.
Yes, sir.
My turn.
Please.
Thank you, Mr. Chair.